Hello, ladies and gentlemen, and welcome to the first meeting and the first debate of the Stanford chapter of the Benjamin Rush Society. My name is Beau Breeze. I'm a resident in emergency medicine here at Stanford, and also the founder of the Stanford chapter of the Benjamin Rush Society. I'd like to thank our speakers for donating their time to participate in this very important and vital discussion about our nation's future. And I also wanted to take the time to thank our co-sponsors for this event, including the Stanford Democrats, Biomass, the Stanford Pre-Medical Society, the Stanford Healthcare Club, the Stanford Federalist Society, and a variety of other organizations that we'll acknowledge at the end. So it is my pleasure to introduce to all of you Jeff Anderson, the director of this Benjamin Rush Society nationally.
Good evening. Thank you for coming. I wanted to extend my welcome. It's good to see everybody here. We have some brochures up here that we welcome you to come up and take after the debate. Please feel free to take as many as you'd like and hand them out to anyone you think might be interested. And we look forward to hopefully a spirited and illuminating exchange of ideas here this evening. Welcome to the debate on the question, the federal government versus the free market, which can provide the more compassionate and efficient healthcare plan for America. Each side has two debaters, each of whom will give a 7-minute opening statement from the podium. Before the opening statements, we will have a vote on the question for the debate. After all four people have presented their cases, each debater will have 30 seconds to ask a question of the opposing side. The opposing side will have 2 minutes to answer. The questioner then will have 1 minute to give a rebuttal to the other side's answer. After each debater has had a chance to ask a question, the moderator, I, will ask questions that have been submitted by the audience and/or questions of my own. Please submit questions by filling out a card, which you'll find on your seat. And if you have a question, you filled out the card, just raise your hand, and one of the Cindy or one of the other folks in the room will come by and grab that from you. After 12 minutes of, or so of a question and answer session, each debater will have 1 minute to offer a final rebuttal to tie up loose ends, and then 2 minutes to make concluding remarks from the podium. And then we will then have a final vote and conclude the debate. I will now introduce the debaters. Debaters arguing for government-based solutions. Dr. Aaron Rowland is a practicing family physician, owner of a small group practice in Burlingame, California, and an associate clinical professor of medicine at UCSF. He is a San Francisco native, a graduate of Ravenswood High School in East Palo Alto and Yale University, where he studied natural resources and public policy. After a brief stint as a quote-unquote policy hack and a year at Yale Law School, he studied medicine at UCSF and completed his residency training at San Francisco General Hospital. Dr. Rowland's 20 years in a private practice of marked ethnic and economic diversity has convinced him that fundamental health finance reform is essential if our nation is to provide high-quality health care for all or any. Dr. Henry Abrams is a retired physician in Berkeley, California. He received his medical degree from Case Western Reserve University and is board certified in internal medicine, pulmonary medicine, critical care medicine, and occupational medicine. He was previously associate professor of medicine at West Virginia University, where his clinical responsibilities focused on critical care, chronic lung disease, cystic fibrosis, and medical ethics. He is on the national board and California chapter of Physicians for a National Health Program. Debaters arguing for free market solutions. Dr. Reed Wilson is a private practice physician in Beverly Hills, specializing in internal medicine and cardiology. He's an attending staff member at Cedars-Sinai Medical Center and a member of the Cedars-Sinai Bioethics Committee. He was founder and president of the Young Physicians Organization, the Young Physicians Charitable Foundation, and Beverly Hills Care, an independent physicians organization. He has served as a consultant to numerous pharmaceutical companies and healthcare research organizations. He serves on the executive board and is chief of operations for Doctors for Patient Care, an organization of physicians committed to the establishment of a healthcare system that preserves the sanctity of the doctor-patient relationship, promotes quality of care, supports affordable access to all Americans, and protects patients' freedom of choice. And finally, Dr. Zwelling. Dr. Marcy Zwelling is a respected member of the California medical community and a prominent voice in the struggle to improve the broken healthcare system. She is a quadruple board-certified physician specializing in internal, emergency, and critical care and quality assurance. Her practice, known as Choice Care, is designed to provide a higher level of access and attention to a smaller number of patients. All right, if you would please join me in welcoming the debaters. Okay, now as our first order of business, if you would please pull out your red, blue, or green cards and cast your initial vote. Again, we'll do a vote now and then one after the debate. If you think the federal government is the solution, please pass in a green card, free market, blue card, and if you're undecided as of now, please pass in a red card. Or I suppose if you're in between, you can pass in a red card. Maybe you could just, let's pass them toward the center aisle, shall we?
It's hard to tell the difference between green and blue.
It is. You don't see many reds, that's for sure. Yeah, they're undecided. Red needs to have a chance.
The blues and greens look too similar.
Well, you're not supposed to be able to see.
But they can't. They're having problems too.
Is anyone having trouble telling the green and blue apart?
It is. It is a conspiracy. We agree.
Okay. Has everyone had a chance to vote? All right. And we will tally those up, and as well as the final vote, and announce both at the end of the debate. Okay. Let me now turn the podium over to Dr. Rowland, the first of our four speakers. Please welcome Dr. Rowland.
Thank you, Jeff, for the introductions, and thank you all for coming tonight to participate in this debate. I'm a family doctor, and I established my practice over 20 years ago based upon a few principles. I promised myself that I would provide the highest quality care I could, that I would do so in an evidence-based manner, that I would turn away no patient because of inability to pay, and that I would make a living doing so. I've been modestly successful at doing all of these things. That being said, with the passage of time, I've become increasingly aware of the barriers I face in creating what one could call a compassionate and effective practice. Over and over again, as I analyze those barriers, I find that it is a huge and complex bureaucracy that stands in the way of achieving my goals. A bureaucracy which seems intent on complicating care for patients and providers, and which often stands in the way as I try to serve my patients' needs. A bureaucracy which focuses more on denying care to the sick than on preventing illness. This bureaucratic opponent I face is not the government. It's the health insurance industry. Let me explain. This binder here contains the reports from the billing company, which I use to bill for my services. It lists 79 insurance companies or other categories of payers with which I have active accounts. What that means in practical terms is that I pay about 7% of my revenues to hire the services of the billing company. That's enough to hire another half-time physician. My mother, on the other hand, she's a Canadian, tells me of a recent trip to her doctor. After they had spoken briefly of my travails in dealing with the insurance industry, her doctor asked if he could see her medical card. He took it and swiped it through a device on his desk. "Well, no problem there for me," he smugly explained. I just got paid. The economic costs of my practice of having to deal with the private insurance industry are huge. Beyond the cost directly tied to my billing, my small practice of 2 full-time equivalent providers employs 6 staff members, at least one of whom we would not need if I had the ability to deal with a single payer. Yet the costs to me of this balkanized system pale by comparison to those of my patients. Increasingly, my insured patients are being forced to buy inadequate health insurance policies, so-called HSA-compatible policies, which sport high deductibles and copays, ostensibly sold to facilitate consumer responsibility and accountability. What happens on the ground, so to speak, is that this increasing patient responsibility, read financial vulnerability, results in many foregoing the care they need in favor of buying their groceries. They present with more advanced disease, fail to obtain needed medications or get important tests, and then if they have the bad luck to get sick, go bankrupt. Let me tell you about one of my patients. Mr. Pui has diabetes and most of its complications. A hardworking airline food preparer at the San Francisco airport, he neglected his diabetes for years. Office visits were rare. I'd long wondered if the expense of medical care was part of the issue, as he had insurance of the sort that required him to pay a significant deductible every year. And when I took over his care from his previous doctor, I noted that his chart had "sent to collections" stamped on it more than once. Mr. Pui first faced his diabetes in a serious manner when he was hospitalized for a vision-threatening fungal infection. Soon afterwards, because of layoffs in the airline industry, he was without insurance and decided to move to Tonga for a few years. When he came back, his diabetes was finally under control. "What happened?" I asked, incredulous. "In Tonga," he answered, "medicine is free." Our healthcare system is badly broken. Although the president's efforts will go a long way to correcting certain insurance company abuses, will provide coverage for millions who are currently uninsured, and will provide better support for public health and cost-effective primary care, we're a long way from where we need to be. I hope to tell you some more stories about my patients tonight, because stories bring life to the argument. But out of respect to the academic nature of this institution, and as Benjamin Rush himself said, because freedom can exist only in the society of knowledge, I will close with a few stark facts from the literature. Medical costs contribute to half of all personal bankruptcies in America. That's 700,000 a year. Yet 3/4 of those who go bankrupt in this way had health insurance. While Americans are struggling under the burdens of uninsurance and underinsurance, the 5 largest insurance companies in 2009 raked in more money than the industry has ever made in a single year. When you combine the profits they made with their direct administrative costs, ignoring for the moment the costs they impose on others like me, they spend more money on things other than health care than it would take to pay for health care for all uninsured Americans. And finally, a polling result. Twice as many Canadians believe Elvis is alive than would want to adopt our health care system.
Dr. Wilson?
I almost threw away my notes today because I saw the stock market go down 300 points, and I figured I'd just come in here and say, we can't afford it. You'd all applaud loudly, and that would be the end of the argument. But I kept my notes. Compassion and effectiveness, one usually thinks that both of those either one goes up and one goes down like a scale. Actually, in medicine, they both rise or they both fall together. I like to see results before I want to change any system. And I ask myself, what are the large systems in our country that we can use for an example? One of those would be Social Security. Very large system, affects everybody. And then I ask, when will Social Security's intake become less than their output? Because that is a sign of bankruptcy. If you ask the trustees of Social Security, that occurs in 2016. I don't want a system like Social Security. Then I said to myself, what's another large venture that the government is responsible for? And I said, how about the post office? The post office is permanently bankrupt. It loses $4.7 billion every year. FedEx and UPS do the same exact business, yet they work at a profit. And who would you rather wait in line, and who do you think is more compassionate? Do you find the post office compassionate or the DMV? I do not. Then let's take Medicare. Both of our opponents, I don't like to call them our opponents, but both of my colleagues who disagree with me feel that Medicare should be something we have for all. But Medicare costs money. And if you take a look and ask, when will Medicare be bankrupt, and you ask the trustees of Medicare, you will find it is happening in a little over 7 years. I don't find compassion. I don't find effectiveness in something that is going to be bankrupt. But then you say, well, we have the Massachusetts experiment. And they just started that 3 years ago. What has happened with the Massachusetts experiment? Let's quote the Boston Globe. The Boston Globe says it's untenable. What has happened with the Boston and the Massachusetts experiment? In 2007, they subsidized $600 million for the care of the people who couldn't afford it. What happened in 2009, just 2 years later? $1.2 billion. That's a 100% increase in 2 years. They've raised taxes. They still can't sustain it. The New York Times, hardly a right-wing organ, is saying this is not working. It's not working. We need something else. But this is not just a matter of money. It's a matter of efficacy, efficiency, and compassion. Remember, wait times might make a difference. What metropolitan city in the United States has the longest wait time now? Boston, Massachusetts. They have more hospitals than I think there's buildings in this city. They have more doctors than anywhere I think of in the world. Those are smart people, too. They're trying hard. You just can't do it. You cannot provide a quality system that has efficiency and compassion in that system. Now, much more important, I want to talk about results. Can you hear me with this far away from the microphone? No. Okay, I'll try to stay really close. Let's talk results. What about mortality? What about the mortality of various cancers measured in Canada, the UK, and the United States? This takes into account all people. It doesn't just take into account poor people, rich people, it takes into account everybody. In the UK, in Germany, you have a 52% higher death from breast cancer, 88% higher in the UK than in the United States. In the UK, you have a 600% increase in death from prostate cancer than you do in the United States. In the Canadian system, you're saying, why are you leaving out the Canadian system? It's 108% higher. Is this compassion when you have a system which leaves out people to die? That's not efficiency. That's not compassion. Let's take another measure of compassion and efficiency. What about taking chronic care of people? What about all those individuals who need statin therapy? I'm a cardiologist. You're going to hear me talk about cardiology things. 56% of Americans who we think need statins can get them. 56% of the entire population. 29% of the Swiss. 23% of the Brits. 17% of the Italians. They all have national health care. I'm told that they can get anything whenever they want. All they have to do is go to a doctor, swipe their card. Why aren't they getting care? Let's talk about preventative medicine. After all, I think everybody here believes preventative medicine saves time, saves money, saves lives, compassionate. 9 out of 10 Americans, American women, have received a mammogram. 3/4 of Canadian women have. Nearly all American women have received pap smears. Less than 90% of Canadian women have. About half of American men have received PSA tests, prostate cancer tests. 1 in 6 Canadians have. About 1 in 3 Americans have received colonoscopies. 1 in 20 Canadians have. Which is compassion? Which is efficient? Which is providing care to our population? Americans are, I'm going to fade into cardiology here. What about the future? What about innovation? If you just take our 5 top hospitals doing clinical trials, that's more clinical trials than is done in any other single country in the world. That's American ingenuity. That's American free enterprise. And then finally, what about Nobel Peace Prize winners in medicine and physiology? Do you know that since 1970, more Americans have won the Nobel Peace Prize in medicine and physiology than every other country put together? Do you think this is a private enterprise system that's doing this, or do you think it's the government's doing it? We cannot afford to have government health care. If you believe in compassion and you believe in efficiency, if you believe in saving lives and having prevention, you go for a private health care system. Thank you.
Dr. Abrams?
I've never been in a debate before. I understand there's an opportunity for rebuttal later. So what I would like to do is just paint for you what is Physicians for a National Health Program and what do we base our views on. We believe that access to high-quality health care is a right of all people. There are 45 million people in this country who don't have health insurance, and we think that that's intolerable. And we believe that health care should be provided equitably as a public service rather than being bought and sold as a commodity. We view this as part of a campaign for social justice. It's not simply a question of health care, although when we look at health care, we find a lot to be dismayed at in the United States. We'll talk about the use not just of isolated facts, but the use of a more global look at the healthcare systems of other countries to see actually what their achievements are. And we don't come out looking very good, in spite of what Dr. Wilson says. We oppose for profit control. We're not opposed to profit in medical device companies, medical equipment manufacturing, drug companies. But we think that the delivery of health care, the relationship between a provider, whether it's a hospital, a physician, a nursing home, a therapist, that relationship should not be based on economics. We think it's governed by certain economic laws, but we think that it should be a nonprofit relationship because it is a service relationship. And we don't think that people should be going into medicine to make money. We do think that the entrepreneurial spirit that brings the application of scientific discoveries to bear on healthcare is sometimes advanced by the selfish interests of wanting to make a profit. But we don't think that the service and the relationship that takes place between a doctor and a patient and these other providers and a patient should be a for-profit relationship. And we especially oppose corporate control of medicine, and we recognize that large insurance companies, which are far more bureaucratic and far more restrictive than government-run healthcare programs, I mean, talk about bureaucracy, your blood pressure will really go up when you start dealing with private insurance. And these companies are bought and sold on the stock exchange, and they're answerable to their shareholders, and their interest is simply in a return on investment, nothing more or less. So we think that healthcare for countries should be financed by progressive taxation. Everybody has a responsibility to pay according to their means. Healthcare is expensive, and society can't, conduct healthcare without adequate financing. We actively oppose any changes in the healthcare system that are designed to maximize the profits of investors or the incomes of high-level executives rather than to serve patients. And we recently saw a dramatic example of the behavior of Anthem WellPoint, one of our most prestigious insurance companies and dearly loved by the people of California, whose CEO was awarded something like $14 million for her efforts on behalf of the public. We do stand, as I think Dr. Wilson so clearly does, and I'm sure Dr. Zwelling would agree, for the restoration of the primary mission of physicians, which is to act as professional advocates for whom? For our patients. Now, we all know that the U.S. has a healthcare system that is unsustainable. It's unaffordable by individuals, it's unaffordable by employers, it's unaffordable by society, as are some other institutions in their present form. And Dr. Wilson alluded to fiscal problems at the post office. He didn't talk about some of the other programs which are on great financial shape as far as I can tell. The government runs the military, the government runs many other programs. I don't see that they're going to run out of money anytime soon. So financing is a problem that can be addressed, and there are problems in the financing of Medicare and Social Security. Public policy, which is designed to create and administer and improve continuously the programs that serve society, should be evidence-based. And I'd like you to consider the market. What is the evidence about the market? If the market was so good, then over the last 100 years, we would have a very different track record than what we have right now. We're the only economically advanced country without health insurance that covers all of our people, and people die as a result of that. The Institute of Medicine said it was 18,000 people a year in 2002. More recent estimates, 45,000. Whatever the numbers, people die simply from the lack of insurance. So there's a lack of fairness, there's a lack of equitability. So let's look at other evidence. What is the evidence that we could use in terms of public policy? We can look at Medicare. Fiscally, Medicare has problems, but in terms of the health care access that it provides to the elderly, and in terms of the high regard with which it's held, and in terms of the security that it yields to the elderly in this country, Medicare is as sacred as motherhood and apple pie. We could look at the VA, which has very impressive health outcomes. We could look at international comparisons. And you've already heard about the disgruntled Canadians, but that's absolute bunk. It's rubbish. You can always find some individuals who are disgruntled. You can find people who have not had the same number of tests. Nonetheless, life expectancy is much greater. I don't think anyone in Canada went bankrupt in the last year because of health debts. I'm out of time, but I would say that medical decisions are best made by doctors and patients. The commitment of social resources and the allocation of those resources is best made by a democratic political process with input from health professionals. And that's why we advocate a single-payer plan for the United States. Not the current government approach, but a single-payer plan which would be much, much better than what our government has accomplished so far.
and Dr. Zwelling.
I'm told I have to put this down because I'm too short. Good evening. My name is Marcy Zwelling-Ahmet, and I stand here proudly as my patient's doctor. Our colleagues have stated that the United States spends twice as much as other industrialized nations on health care, $8,160 per capita. Yet our system performs poorly in comparison, and they, quote, leaves 46.3 million without health care coverage and millions more, quote, inadequately covered. While we could debate the number of uninsured, I would say that's reason enough to turn away from our government-regulated, overly mandated healthcare system. This is because private insurance and government bureaucracy and paperwork consume 1/3 or 31% of every healthcare dollar. Again, a quote. Streamlining through the free market and a consumer-driven system would certainly save at least as much as the $400 billion per year, enough to provide comprehensive, high-quality, affordable coverage that is accessible and compassionate for all Americans. Insurance is not assurance of a darn thing. Our emergency rooms are full of Americans with a card, a Medicare card, a Medi-Cal card, a Medicaid card, an insurance card. They sit for hours. Sometimes that card offers more in obstruction than it ever does for care. It certainly doesn't describe a compassionate, caring system. I believe that every physician in this country, not just those on this stage, would agree that paperwork and administrative hassle interfere with our opportunity to take care of our patients. And we all want to blame those daggone insurers. And I'm not here to condone a thing that they do. But most of their burden comes from the government. It comes from government provisions. It comes from government mandates. I would go so far as to argue that even with that ultimate single-payer system, a one government-run system, care could indeed be very inexpensive, certainly for the patient, for that patient getting care. But the care would be random, if not perfunctory, population-based, if not paper-based, and incredibly costly in terms of days of work lost, opportunities dissolved into a daily frustration and an expectant humanity traded for a massive despair and banal, thoughtless dissatisfaction. Health should be, it's an investment. It's a personal investment, and that all that must be available in the free market to help take care of oneself and one's future. Affordable and accessible care in a transparent marketplace offers choice and opportunity for that more productive day. I was a major in economics at Wellesley. I won't tell you when. But part of my thesis was about precisely this, the economics of healthcare delivery systems. We know that copays don't do much except perhaps trim a little bit of the demand. It offers an opportunity to tinker, but it doesn't provide a means for any patient to get an opportunity to purchase value-based health care, that experience that I offer as my patient's doctor. It certainly isn't anything about a pleasant medical care experience. In reality, copays often offer the patient the chance to sit anxiously in that waiting room, either in an emergency room or in a doctor's office, waiting for that 9-minute on average visit so that he can figure out what he can do to address that patient's medical needs. It generally is very unsatisfactory. Compassion just can't be sold in a 9-minute visit. Surveys have documented that the intent of doctors today is to retire early. We've already seen some of our best hands-on nurses emigrate from hands-on nursing into administrative systems. Evidence that our system just doesn't work, a system that really has very little room for compassion and for kindness. In order to control cost The economics tells you the patient must have a hearty piece of that last dollar expended. It's a fact. They gotta have skin in the game. The cost of care need not be expensive. In my community, a mammogram costs $75, a CT scan $250, an MRI $350, cash, no card, cash. And when do I get the results? Then, immediately. When does my patient get care? Immediately. I will give you an anecdote. My patient, with insurance, came to me because she had radicular pain. I gave her some steroids. It made the pain better immediately. She was ready to go back to work when her pain recurred. I told her that in order to take the next step, she probably needed an epidural and an MRI, but her insurance company said no. She needed to go to another doctor to get his or her approval for some medication before the MRI. She went to that doctor. She was given the medication and told to come back in 2 months. She went home, out of work. Couldn't work. She called me. What do? I said, simple. Go pay for an MRI, $250. She said, my gosh, that's less than a day of work. She paid for an MRI. I sent her to the gentleman to do the epidural, and she was back at work the next day. A productive day. That's what we deserve. That's what our patients deserve. That's what we sell. That's compassion. The product that a doctor sells their patient isn't an MRI or a lab test. It's the opportunity for a productive day. That's the right we give patients in this country. And that can only be found in a system where the patient has skin in the game, where they can find a doctor that will help them directly, immediately, with compassion and kindness for individualized, personalized care. Not a P4P system, not a paper-based system, not some kind of population-based system where you got to jump through whatever hoops to get your patient the care they need. Systems in government don't make compassion. Government sells process. It's not kind. Thank you very much.
All right, thank you. Each of the 4 debaters will now have an opportunity to ask a question of the other side. And while they're doing that over the next few minutes and answering those questions, I encourage those of you who have questions of your own to please fill out cards, and hopefully we can get to as many of those as possible. So let us start with first question. Each of these questions will be hopefully 30 seconds or less, and then whoever is asked the question will have 2 minutes to respond, and then the person who asked the question will have 1 minute to rebut that answer. So let us begin with Dr. Rowland. Would you please ask the first question of the other side?
Okay. Dr. Wilson, I want to say I wish my patient.
Ask both of us.
Well, I have comments for both of you, but a comment is for both of you.